since there are not genetic counselors universally in all cancer centers, sometimes there are barriers for those folks to be able to access a genetic counselor. And I think another very large barrier is that across the country, we're not systematically identifying people who would be candidates to think about testing.
That's Joy Larsen Haidle, a genetic counselor at North Memorial Health Cancer Center. We'll hear more from her later in the show. Welcome back to Cancer Buzz. I'm your host, Summer Johnson. Hereditary breast cancer is a concern for oncology professionals, with BRCA1 and BRCA2 mutations accounting for a large part of inherited breast cancer cases. We know that BRCA mutation testing allows care teams to create more informed treatment plans, but an ACCC industry assessment in 2018 showed underutilization of BRCA testing, leading to a big gap in care. Since then, through its BRCA project, ACCC has worked with community cancer centers on quality improvement to identify gaps and increase access to the testing and genetic counseling. In 2023, ACCC launched its 2023 BRCA testing Reassessment survey. Our guests today will discuss its results and the latest developments and improvements in BRCA mutation testing, the challenges faced by cancer care centers, and the impact on treatment and care. Lillie Shockney is a University Distinguished Service Professor of Breast Cancer and Professor of Surgery at Johns Hopkins University School of Medicine in Baltimore.
So one of the barriers is a shortage of genetic counselors to be able to meet with the patient, counsel them, and go ahead and do the test, and then follow up with that patient after the test results come back to explain what they mean. This obviously is a pivotal position in the cancer centers. So though we would like to see more people choosing to become genetic counselors, we are not seeing that happen. The other issue is physicians may not be well educated in knowing the importance of doing genetic testing and who should have genetic testing. So 100% of metastatic breast cancer patients are to be tested. Patients with earlier stage disease with a significant family history, that same patient population who is triple negative, those are all red flags for possibly carrying a gene mutation. And someone that is young, is under the age of 45, is also a third flag.
How do some of these challenges affect patient referrals and the overall care process?
We do know that not everybody has access to be able to go to a breast cancer tumor board and present a case. So that certainly can be one of the issues. Patients are now accustomed to doing things at home, like a self-COVID test. So they say, well, can't you just mail me something? But they may not be doing it correctly if we do mail them something to then send in. And when do they send it in? Do they send it in immediately or do they wait a week? All those things are out of our control and can factor in delays as well as having the test not take place at all.
What are some of the highlights that came out of the 2023 BRCA testing reassessment survey?
So first, let me tell you that these surveys started back in 2018 with ACCC conducting a survey that included 95 community oncology practitioners in the United States. So we could figure out what the status of BRCA mutation testing was for patients who were diagnosed with breast cancer. ACCC has reassessed the status of the BRCA1 and 2 testing, given changes over the past 5 years, including the revisions that were made in clinical guidelines that also included a challenge of getting people even to be able to see them face to face, much less draw blood or do a buccal sample, because of the COVID pandemic. That really uprooted everything because you can't get it through a computer screen. That is for sure. That does not work. So between 2018 and 2023, we saw actually a threefold increase in the rate of routine ordering of BRCA1 and BRCA2 mutation testing for all breast cancer patients. In 2018, we had only a 7% incidence of early stage breast cancer patients being tested and 14% of metastatic patients being tested. But for 2023, we did see a really nice jump of 23% for early diagnoses and 41% for metastatic. Now, we still need to get that number up. I'm pleased to see that it did go up. But frankly, for metastatic, the standard of care is to do 100% because there are treatments that are specific for women who carry a BRCA1 or BRCA2 gene and have metastatic disease. So by not testing them, they are not receiving the benefit of specific drugs that have been developed that only work for BRCA1 and BRCA2 gene mutation carriers who have advanced disease.
Are there any shortcomings in gene testing, and what are some of the lessons learned from those?
I think one of the biggest lessons learned, in my opinion, is that we are still way off the mark from where we should be as to who meets the criteria for receiving gene testing, gene mutation testing. We're doing better, but we've still got an awfully long ways to go. So one of the ways I think is helpful is by educating the patient, educating society about breast cancer gene mutations and what do they mean and how do we figure out if you have one and who should be tested, et cetera.
What does good shared decision-making look like?
What we need to do in order to do that shared decision making is empower the patient with information that they can understand in layman's terms so that they can feel confident in participating in the decision making about their care. So we shouldn't be doing things to them. We should be doing things with them. And if we do take that time and really do empower them, they're going to feel more confident in the choices that are made because they're a part of that choice.
How do you think care teams can improve the quality of care for patients with breast cancer?
Well, I think what is needed, and it's a buzzword, but for me, it's a philosophy, and it's called patient-centered care. The patient is more than her pathology. She's more than the stage of her breast cancer and its grade and what its ERPR and HER2 are and other biomarkers. She had a life before she got diagnosed. She should have a life during her treatment. And if she's got stage 4, she should still have a life all the way to end of life. And that means asking her a series of questions. I want to know if she's married. I want to know if she has children and how old are they. I want to know where she works and does she enjoy her job. I want to know what barriers to care she might be having, which could be financial barriers, could be transportation barriers. Maybe she has myths about breast cancer and thinks, well, if you've got it, then fate means you're going to die, so why bother to have treatment? And I've certainly seen people that have come in such a situation.
What's the impact of a good care team on a patient?
I will say this. We may see, I know I certainly do, thousands of breast cancer patients in our career. She only sees one of us. If we took good care of her and factored in all these things that I've just said, she will remember us forever and remember us very fondly. If we failed her and didn't ask her any of this, she's going to remember that too.
What advice do you have for your colleagues?
For me, one of the most important take-home messages is that we know that we are still underreporting how many people have a breast cancer gene mutation. And we know that because not everyone who's supposed to be getting tested is getting tested. So some portion of those are going to test positive. Right now, we're looking at between 5 and 10% of breast cancer patients carry a gene mutation. Once we, and I'll be optimistic and say once we accomplish the goal of getting all of the right people tested, that number is going to go up. In addition to that, this can't just be a one-time test experience. We can test for BRCA1 and BRCA2 once, but there are other breast cancer gene mutations that we've learned in the last 2 decades. So if someone tested negative, let's say 25 years ago, there are other breast cancer gene mutations that she should come back and get tested for, because she may not have carried BRCA1 and BRCA2, but she carries one of these other ones. She might have Lynch syndrome or Cowden syndrome or P53. There's a whole laundry list of new mutations that have been identified. So testing once for BRCA1 and BRCA2 is okay, but not testing for the other gene mutations is not okay.
You heard from Joy Larsen Haidle earlier in the show. Haidle is a genetic counselor at North Memorial Health Cancer Center in Robbinsdale, Minnesota.
There are some professional organizations that are recommending that all individuals with breast cancer, both male and female, pursue genetic testing. There are other triage, like through NCCN, for example, where it's still being the criteria to think about who should think about testing would be based on their age at diagnosis, the type of breast cancer, what family history looks like. But since testing is more and more being used to help guide treatment decisions, and we're thinking about people long term as far as what they might want to think about for their surgery, and then after this breast cancer diagnosis, how do we follow you to help protect your health and reduce the likelihood that someone's getting caught off guard with something else down the road.
Tell us about some of the barriers that persist in genetic testing and counseling.
Some of the bigger barriers that still exist is just globally a lack of awareness amongst the general public and even amongst provider communities. It's always easier when there's a genetic counselor on staff to be thinking about genetics, the utility of genetic testing in each individual case. But since there are not genetic counselors universally in all cancer centers, sometimes there are barriers for those folks to be able to access a genetic counselor. And I think another very large barrier is that across the country, we're not systematically identifying people who would be candidates to think about testing. Often, our providers are super busy. So family history is often collected to a degree that's sufficient to do a brief triage, or it's not collected at all because we're focusing on much bigger topics, such as like, what is your treatment plan and prognosis? So we're missing folks who could be candidates to do gene testing in comparison to the number of people that actually should be.
Genetics play a unique role in BRCA mutations. Explain to us more about that and the importance of collecting genetic data and talking to family members about this disease.
So often when people think about the breast cancer genes, they're not necessarily thinking, hey, you know what, that could actually apply to me. It's usually other people who they were either diagnosed really young, they have really strong family histories, but they're not necessarily saying that really could be me. And with how broad the testing criteria has gotten, it's pretty close to 1 in 7 people would have an identifiable inherited risk that could be used to guide their treatment. So nowadays, when we're thinking about, am I the person that needs to see a genetic counselor? If it's not brought up in an oncology setting when you're meeting with your providers, I would encourage the patients to be more comfortable of raising that question and asking about it on their own as well. But I think genetic counselors are part of that multidisciplinary team. We're working side by side with our docs and our surgeons and our nursing colleagues to help make sure that the patient has the optimal care.
How have recent developments helped address some of the historic challenges for this type of care?
So in the past 4 years in particular, the ability for patients to reach out and see a genetic counselor via telehealth has rapidly improved access for providers across the country. Like I said, the hard part is being able to identify who is somebody that I can access. It's also helped in facilitating the ability for providers to contact genetic counselors to add that expertise as part of their routine tumor boards or their case conferences. So that, I think, has been really helpful. Some of the nuance to the challenges that has emerged as a part of the telehealth is we're used to patients when they're in person, they're often getting a blood sample drawn. So it's pretty easy to predict when those results would be available. It's usually 2 to 3 weeks from the time a sample is drawn. But when we're doing testing via telehealth, it's adding a new variable in that the patients then they're the ones that have another role to play as far as when they get the kit, when they choose to provide the saliva sample, when they're able to get that shipped back to the laboratory. So the length of time to receive those test results has a little bit more of a variable component to it than what we're traditionally used to.
Why is the role of a genetic counselor so important?
There's so much that we are able to offer. When we talk about precision medicine, I mean, our providers are able to select those medications that may help improve the odds of this cancer responding to that medication. We're offering more detailed surgical options that are more tailored to that specific person's individual risk and their family history. It allows the patients to really become a part of that decision process in that they're actively involved in that conversation and adding their opinion on their preferences on what they wish to do. But when we think about these folks, we're also thinking about them long term. Are they at increased risk to develop other cancers? So are we following them the right way? Should we be thinking about risk reduction for cancers that we might not have been thinking about based on family tree? So in the years that I've been doing clinical genetics, I mean, it's been about 28 years now. I mean, I think the most gratifying thing that we've seen is those past family trees often had significant amount of cancer in them. But now that we've been doing genetic testing and people are able to do the heightened surveillance, they're starting the surveillance at younger ages, they're thinking about risk reduction.
What are some of the persistent barriers that providers are facing?
I think one of the biggest barriers that all of us as providers are facing with access to a genetic counselor is in part that we need more genetic counselors, but withholding some of that progress back of increasing the numbers and being able to bring a genetic counselor into a community oncology practice or into some of these smaller settings is that genetic counselors need to be recognized as providers under Medicare. And until that happens, it reduces the ability for us to have reimbursement, and more of that cost falls onto those individual provider communities. So I think if we're all working together to help address that, that would be of benefit to our patients and benefit to, our oncology teams too.
Thank you to our guests today. You can head to the show notes for more resources on BRCA mutation testing. This episode was made possible through funding from AstraZeneca. Until next time, for the Cancer Buzz team, this is Summer Johnson.
This show is a resource of the Association of Community Cancer Centers.